medications for today, but we'll get through them and put them in buckets and kind of, hopefully by the end of the lecture, know exactly how to manage these type of headaches and then how to keep patients from having these headaches. Mainly today is about acute versus preventative therapy. All right, so we've come a long way, right? We don't do, opening up the brain anymore for headaches. And also in pharmacology for modern times, there used to only be a couple of options. Ergotamine we'll talk about today. We kind of got away from that. Some opioids, kind of moved away from that because we have some specific medications, specifically the triptans for migraines, and also some more modern preventative and treatment, which are some neuropeptides, calcitonin, gene-related peptides, both injections and orals, that can treat migraines and also use it for migraine prophylaxis. So we'll get into those. And then we'll talk about the VA/DoD guidelines for primary headache treatments. But the most important thing is for the boards, right? So I'm going to make you aware that there's a 2023 guidelines for the DoD out there. Most of it is syncing and jiving with what we want to see on the pants and what you'll see in phase 2, but the testable material will be not directly off that slide unless it matches. So not a whole lot of pathophys today. We'll get into just the stuff we need to know for the specific medications. All right, so we're going to basically talk about the primary type headaches, differentiating between the diagnosis of migraines, detention, and clusters, and then selecting how to get rid of the headaches, i.e. treat them acutely, and then how to prevent them from returning. We'll also talk about some medications that cause syndromes, which shouldn't be new to you. I'm sure you've had serotonin syndrome quite a bit, but we'll talk specifically about serotonin syndrome as it relates to headache treatment. Right, so like I said, a lot of drugs, but basically we're going to put them into buckets for acute treatments, which aren't that much different from what you've seen with other disease processes, such as OA, those types of things that usually going to start with some acetaminophen, maybe NSAIDs, then we'll move into specifics like the triptans for migraines, orgotes, as I mentioned, they're kind of old. This slide, particular for these next two slides, particular for this lecture, is beneficial when you're studying to go back and say, okay, what is the medication class that we're talking about here? And you notice that there's only a couple of drugs listed in each class. That would tell me that those are the important drugs to know in those classes when it comes to headaches. You don't see a giant list like when we talk about the ARBs, there's a couple there. Beta blockers, there's 3 there. So in headaches, those are the meds from those classes we're going to talk specifically that have the most evidence-based findings. That's why we use them. So if you see a beta blocker, or if you see an ARB, or if you see a triptan, on boards or in testing for headaches, it's going to be one of the ones that's listed on these slides. Not going to be bringing in a random beta blocker or ARB. Then opioids, we'll talk about butorphanol and why we don't use it. And then antiemetics and just know the classes. And once again, you've had nausea and vomiting, so you know all the antiemetics that can be used. But for this class, for headaches, those are the big players on this slide. And then kind of maybe you haven't heard of cyproheptadine. It's an antihistamine and a serotonin antagonist that we'll talk about as a reversal agent. That one may be new to you. And this is just continued. Once again, as I mentioned, you see for the TCAs, for example, not like you had last semester, all this big list of TCAs. For headaches, we're going to talk about amitriptyline and nortriptyline. Same for antidepressants and SNRIs, then venlafaxine. So not a whole giant list of those classes. just the meds on these slides, or in the lecture, but mostly just what's listed there. Okay, there is International Headache Society, 2 classifications: primary, as I've mentioned now a couple of times, which are what we're going to talk about today: migraines, tensions, and cluster. We'll talk about differentiating those out. We used to talk about with aura, we used to call that classic. Without an aura, we used to call that common. We're just going to put everything into migraine buckets today. Migraine's a migraine. We don't have to differentiate between the classic or the common. And then there's tension headaches and cluster. Those are your primaries. There are some others, like mentioned there, primary cough, primary exertional. We're not going to get into those. And then secondary headaches. These are ones that were more concerning. Not migraines, not tension, not clusters. So we got to figure out what's going on with this patient. Head or neck trauma can cause headache, i.e. whiplash. Cranial or cervical vascular disorder, stroke, TIA, arteritis, big players, dangerous stuff. Infections or psychiatric disorders. So just know how it's broken down, the primary and secondary, and then the main things we're going to talk about today are primary and those subclasses of primary. So you'll see on this slide now, we're talking about migraine. It's not on a slide. I'm going to make one for you and add it to the slide deck. But you'll see as we look at the top there, headache diagnosis, see where it says snooping going across? S-N-O-O-P, so write this down. I will add a slide. So these are your red flags, like considering this is not a migraine if these signs and symptoms are present. The first S is systemic symptoms, or the only S, systemic symptoms. The N is for neurological deficits. O, onset is sudden. Second O, older age. And then a P is for a pattern change, or change in the pattern of the headaches. So when we see headaches that are falling into those signs and symptoms, we're more worried about figuring out what's going on with the patient. We're not treating that first, right? If it has some of the characteristics of Snoop, those red flags, we got to look at more diagnosis, right? Are we doing special testing, lab work, imaging, finding out exactly what's going on? If there's systemic symptoms, neurological deficits, onset is sudden, older age, or pattern change. It's just a quick way to ask, which category you're falling in. Now, to contrast that, pounding. Pound. These are your migraine criteria. So the P is for pulsatile. The O is 1 day duration. U is unilateral. N, nausea and vomiting. And D is disabling. So quick down and dirty to classify migraine, not migraine, or a secondary type headache that we need to do some more investigating and clinical workup on is Snoop versus Pound. I will add a slide when I add the check on learning procedure with those on it. And then there across the bottom is what the meat of today is. Yes?
Could you run through?
Yep, sure can. All right, so Pound, pulsatile. 1 day, lasts 1 day. Unilateral, so one side of the head. Nausea and vomiting is the N, and D is disabling, out of commission. Disabling. Everybody got it? Like I said, I'll add a slide. I think it was in before, and then in the rewrite, we lost it. So. All right, triggers, migraine triggers. They matter. It's not just pharmacological, right? Common triggers: stress, sleep, hormonal changes, caffeine, which none of us have too much of that, right? Dehydration, skipping meals, and yes, PA school, right? A known trigger. If you don't address the lifestyle factors and you don't throw meds at migraines, treatment's going to fail. So with migraine, treatment, you always have to counsel on the triggers, lifestyle changes. And that is board testable as well. So, very important concept. Okay, so migraines. There's a better slide to talk about the pathophys when we talk about triptans, but the main thing is to know that migraines are not just vascular, right? It's neurovascular. And basically it's activation of the trigeminal vascular system, which leads to CGRP release. And we're going to talk about that. You don't need to write all this down. But that CGRP is released when that trigeminal neurovascular system is activated and you get inflammation, and you get vasodilation, and you get pain. So that concept is why the triptans work, and also why we use the new CGRP antibodies, the calcitonin gene-related peptides for treatment and prophylaxis. So main take-home point as we talk through this, migraines are centrally mediated, right? We'll talk about the pathophys of it. It's not just a blood vessel problem. All right, so as you saw in that slide a couple ago, for all the three primary type headaches, we're going to talk about acute, how do we treat it, and then prophylaxis, how do we keep them from returning. Acute equals abortive, right? We want them pain-free in 2 hours. We want to return function in an hour. If there's no improvement in 2 hours, you can repeat a dose once if we're talking about triptans. Super important concept. You can take a triptan, most of them, one of them is 4 hours, but kind of rule of thumb for the triptans, and we're going to talk about what they are, what they do, but to meet the goals, you can take another one at 2 hours, not at 3, not at 4, not at 5, not at 6 hours, you take it at 2 hours. Hugely testable. It's at 2 hours. If it's taken at 10, you can take it at noon, not at 13, not at 14. And then you can only take 2 doses of triptan in a 24-hour period. So our goal, pain-free 2 hours, restore their function in an hour. We want to keep them from reoccurring, and then we want to have minimal adverse effect from whatever treatment we're giving. And I told you can repeat a triptan once in 2 hours. Except there is one caveat for one of the triptans is 4 hours. And then when we talk about prophylaxis, if you're having more than 4 headaches a month or 8 headache days per month, you need to be on prophylaxis, i.e. something to keep you from having the headaches, migraine headaches reoccurring. With prophylaxis, we can decrease disability days, and we move to that when we start to fail acute therapy, or like I said, you're having more than 4 headaches a month or 8 headache days a month. If you fail acute therapy, we'll try on prophylaxis. Also, if you're starting to over-medicate, we're going to talk about medication overuse can cause headaches as well. We want to get someone who's using medications too often, too much. As we always say, too much of a good thing can be a bad thing. So if they're having medication overuse headaches, which is what you're trying to treat in the first place, then we need to get you prophylaxis because you're having headaches from using too many medications. So kind of a pearl here, if they're telling you the patient has 6 migraines per month, they need prophylaxis, right? That is too much. It's too debilitating. And now I'll throw this out there, but on the next slide, basically what we're going to talk about is the treatment algorithm. And it's just like I said, you're going to start with your analgesics like acetaminophen and your anti-inflammatory NSAIDs. Then next will be a triptan. And then if they fail the triptan, well, let's add an NSAID to it. See how that does. And then if they're having frequent migraines, the numbers that I just mentioned, then you're going to talk about prophylaxis. That's all there is to it. That's the whole treatment algorithm for migraine. Except for there's a whole bunch of meds in each of those steps. Treatment has to be individualized. I mentioned pain reduction in 2 hours, get the function back, reduce recurrence, and try to use something with the minimal adverse effects. If NSAIDs fail, we'll move to a triptan. If triptans fail, add an NSAID to the triptan or switch triptans. And we'll talk about that when we get into that class. There are some combinations of some triptans with an NSAID, with naproxen, and then the CGRP agents either can be used acutely or in preventative. There are some disability assessments out there. You hear about the headache assessments. The MIDAS is the Migraine Disability Assessment. There's the Monitoring Headache Response Migraine, the MTOQ4, the HERT questionnaire. You don't need to know all these questionnaires. They exist. We're going to talk about the signs and symptoms, the number of headaches, how severe they are, and when we use the medications. But you may see these in some of your phase 2 sites. The board is never going to ask you for those specific questionnaires. Like if there's like one guideline, a lot of times the board will key in on it. But when you see there's just 5. There's plenty more. So we're not going to test you here. The board's not going to test you on certain questionnaires, but they'll question you on the concepts, right? Which we'll get into what those are. Okay, we can't ever underestimate this slide for treatment. It's not just medication. You got to avoid the triggers that we talked about, or the patient has to. It helps to get in a dark, quiet room with migraines. If any of you have ever had migraines or know someone who has, that's like the first thing that they want to do is get to a dark, quiet room. Turn off stimulation to the brain. Ice packs can help. Sleep hygiene is a huge one. We mentioned that being on the trigger slides. Eating in regular time, regular meals, and reducing that caffeine. There are some behavioral interventions that can be utilized as well for some folks. So never underestimate non-pharmacological treatment. Just like the trigger discussion you have to have with your patient, you have to bring in the recommend the non-pharmacological treatment as well for the migraines. But a lot of it's intuitive. The patient is going to want to do those things out of the severity of the signs and symptoms that they're having. Here's the 2023 VA/DoD guidelines, or CPGs, clinical practice guidelines. Mostly follows everything else. Same thing, acetaminophen and NSAIDs for a migraine. Then move into the specifics, which are triptans and ergots. This one, the DoD guidelines for the NSAIDs and acetaminophen, basically poo-poo on those two. But the board is still going to say, if they're mild, that's your treatment of choice, first treatment of choice. But weak evidence per the DoD for the acetaminophen and NSAIDs. Specific therapy recommended the triptans and the ergots, which have kind of fallen out of favor, as I mentioned. We'll get into. Then miscellaneous, the butorphanol is opioid agonist. That's big poo-poo on that one. It's a last resort. We're not trying to get people on opioids or controlled substances that have migraine headaches. And then antiemetics we'll talk about because, as we mentioned in the PHARM acronym, nausea and vomiting is one of them, so we'll have to talk about antiemetics. So your exam pattern, whether DoD or the boards, is going to be mild, Tylenol, then move into an NSAID, moderate to severe, move to a triptan, and then if it's severe and you got some vomiting, throw on an antiemetic with triptan. We'll get deeper into that. So OTC, first line, migraines, to stop, abort the active migraine. Acetaminophen, then NSAIDs, as I just mentioned. Then once again, the specific therapy, triptans or ergotamines, which are specific for migraines. And then the miscellaneous, stay away from butorphanol, nasal spray, if at all possible. And then the antiemetics, which metoclopramide is going to be your big one. Reglan is going to be the big one you're going to see on the boards and in practice if we throw on an antiemetic with a triptan. which you could consider if the patient has severe nausea and vomiting with their migraine. So this is the medication overuse headache that I discussed, also called rebound. You'll see it a lot with the analgesics, the opioids, the ergots. That's why they kind of fallen out of favor, ergotamine, is because medication overuse headaches are rampant with the use of that medication. You do sometimes get medication overuse headaches from the triptans, which are specific for migraines, but that's when we start looking at moving to prophylactic. We gave those number of days of headaches and days that you're seeking treatment. So if you're doing 2 days a week is kind of the thing to know. If you're having to use abortives like the triptans more than 2 days a week, we need to get you moved on to a prophylaxis treatment. What's the treatment? If you have medication overuse headache, you guessed it, stop overusing the medication. That's the treatment. Medication overuse headache, stop the player, right? Stop whichever medication they're on that they're having to take so often. Discontinue it. That's the answer. And expect the patient to get worse before they get better when you discontinue the abortive therapy that they're taking more than twice a week. It's easy to understand that headaches are going to get worse if they've been chronically more than twice a week using an acute abortive therapy for their headaches, and then we stop it altogether. So it's going to take, a month, 2, for the medication overuse headache to kind of stabilize. The big one, I guess I'll have to show the opinion. All right, so discontinue the offending agent, expect worsening. The big players, opioids, barbiturates, and benzoids, which I'm sure you had last semester, but those guys you might have to have medically supervised withdrawals or tapering off those medications because of the side effects with abrupt cessation of the med. So if you see on exam a patient's taking a triptan every day and their headaches are getting worse, what do? Stop the triptan. Easy. All right, Tylenol, we've talked about it in lots of classes, I'm sure. Not fully understood. Analgesic, so decreases pain, decreases fever. Does not have an anti-inflammatory effect like the NSAIDs. We're going to use it in mild migraines. DOD says no good, don't recommend it. But boards are still going to say very mild. You can try first line acetaminophen. About 1,000 milligrams for an acute migraine. It's a weak recommendation from the DOD. The pain response in general is usually inferior to NSAIDs because it doesn't have an anti-inflammatory effect. And I gave you a brief rundown of how migraines happen from that trigeminal cascade, releasing CGRP, which causes pain and inflammation. So NSAIDs are usually a little better, but it's okay to start with Tylenol if it's very mild. But just remember, board-wise, NSAIDs are usually a little more efficacious than Tylenol. Okay, here's a combo with Tylenol. Don't use it. May or may not be in your formulary, but it's going to be Tylenol or aspirin with butalbital. So the one with aspirin is actually a controlled substance versus the one with Tylenol. Don't ask me why. Probably has to do with the fact that if you overuse or overdose on the aspirin one, it's a much tougher clinical presentation to reverse it than with the Tylenol. But the butalbital, it's a barbiturate. So coming off of it's bad, people get addicted, sedation, respiratory depression, highly abused, withdrawal risks off of it, causes medication overuse headache. So just avoid it. But you will see it out there. Furanol and Furacet is probably going to be a distractor. It may or may not be in your formulary wherever you're working, but I would avoid it, or else a lot of times because of those side effects and the dependence that can be had by being on that medication, I would avoid a controlled substance. If they say Furacet versus a triptan, it's triptan on a test. It's outdated and inappropriate by today's standards, but you will see it out there. You will see folks still using it. Excedrin migraine, right? OTC. So now we add caffeine in. So what does caffeine do? Blocks the adenosine receptors, so you're going to get catecholamine release. So mild to moderate migraine, we can try, aspirin or Tylenol with caffeine. But once again, if you're using this a lot, if you stop taking caffeine, what happens? You get a headache. So you're treating something, and the patient's using it a lot, and then when you stop it, or when they're not taking the med, now they've got the exact same problem that they came to you for. Just a different etiology of their headache, but now they get a different type of headache, a caffeine withdrawal headache. Kind of the same thing, if you see somebody on a test, patient's taking Excedrin, and their headache's getting worse, and they're taking it daily, medication overuse. How do we treat it? Stop. Stop the Excedrin migraine. Okay, NSAIDs, foundational for migraines. We know them, we've talked about them, I've talked about them with you, so we know what they do in the COX inhibition. Going to decrease prostaglandins, decrease inflammation. Mild to moderate is where you're going to use NSAIDs. Why? They're cheap, they're everywhere, but the risks, right? The risks come back. So GI bleeds, kidney impairment, cardiovascular risk. We kind of have a rule there at the bottom of the slide. 15 days. Seems like a lot, but okay. If you can tolerate the GI upset, or you don't get a GI bleed, and you don't have a cardiovascular risk, you can use them up to 15 days a month. But you're risking MOH if you get up towards that upper level or above it. If someone has coronary artery disease, do we tend to use NSAIDs? Usually not, right? So be cautious, big thing with the NSAIDs. You should know this by heart by now. CV, GI, kidney, caution. I did not add the money slide picture that's spinning around there, but yeah, I guess this is the money slide. I guess that's what that means. I don't know. So we're on to triptans. Triptans are specific to migraine. Yeah.
Sir, what's MOH?
Let me go. That's the medication overuse headache. Okay. Medication overuse headache is the MOH that you see there. Too much of a good thing. Triptans, got to know them. So what do? They're agonists on the 5-HT1B, 1D receptors. And they also act on the 5-HT1F. You don't need to know all that. Basically, when you give the triptan, what you're doing is reversing that cascade. When I talked about the trigeminal pathway being activated, releasing CGRP, which increases inflammation and vasodilates, you're reversing that. You're vasoconstricting with the triptan. So you're inhibiting trigeminal nerve activation, which is what sends the pain signal to your brain, right? So you're inhibiting that trigeminal nerve activation, and you're reducing the neurogenic inflammation because you're decreasing that CGRP release. And you can follow the numbers there to see what's happening. The important thing here is you see there's two mechanisms, right? You're seeing what's happening at the vessels, and then you're seeing what's happening to the autonomic nervous system. So, and I mentioned that at the very beginning for migraines, that it's not just a vessel problem, it's also autonomic regulation. So you can see on the far right with the stimulation of those receptors, the agonist activities of those two different receptors, where it's acting on the autonomic and where it's acting on the vessels, to vasoconstrict and to shut down that pathway for the trigeminal nerve activation, and some facial nerve activation if you follow it all the way down. Moderate to severe, triptans, failed Tylenol and NSAIDs, triptans. Don't use triptans in coronary artery disease, uncontrolled hypertension, and there's another slide for it, but stroke or hemiplegic migraine. What does hemiplegic mean? One side, right? So a hemiplegic migraine, this won't be on the test, except for possibly a contraindication to triptans. But a hemiplegic migraine means you have muscle weakness on one side of your body, so kind of stroke-like presentation. Or a basilar migraine, which means it starts in the brainstem and you lose kind of your coordination, those kind of things. But those are the contraindications. Not super testable, but you can't use. Those are two specific types of migraine etiology that you're not using the triptan. Once again, how many doses can you have in a 24-hour period of triptan? Which is how many hours after the first one? 2 and 2. Straightforward. Do not combine with ergotamines within 24 hours. Hugely testable. We'll get there when we go through the ergotamines. Put that in your bank, in your test bank. You do not use ergotamines within 24 hours of a triptan. And then also caution with SSRIs or SNRIs. Why? Serotonin syndrome. Because you've got your triptans working on serotonin, and then you've got your SSRIs and SNRIs, which increase serotonin levels, so you can get serotonin syndrome. All right, rapid fire here. NSAID failure. What are you going to use for migraine? Next. NSAID failure leads to triptan. All right, I'm taking a triptan daily. My headaches are getting worse. What type of headache? Medication overuse. Patient with CAD, coronary artery disease, migraines. Triptan or no triptan? No triptan. Took ergotamine today. Can I have a triptan? No. Deal. Good deal. All right, a lot of them there. Big differentiation on that chart is short-acting, or the sumatriptan, the rizatriptan, and zolmitriptan. Faster onset, short half-life, but high reoccurrence of the headache. They're in and out quick, right? They do their thing, but they're fast-acting and short half-life. Longer-acting, or the frovatriptan and naratriptan, slower onset equals longer half-life. I would know that the longer-acting frovatriptan and naratriptan are useful for menstrual migraines. That's a heavily tested board question. Menstrual migraines, longer-acting, frovatriptan and naratriptan. But we're also going to use the longer-acting if patients are prone to reoccurrence of their headaches, right? Why not give them something that has a longer half-life, stays in their system longer? So if your patient is responding to one of the shorter actors there, one of those three, but they're having a lot of reoccurrence, you can give them a longer acting before you start putting them on prophylaxis if they're hitting that cutoff. But if they're having menstrual migraine or recurrence a lot, or recurrent prone headaches, migraine headaches, think about a longer acting. There's only two there, the frovatriptan and naratriptan. Comes a lot of different packaging, right? A lot of different routes. PO, intranasal, sub-Q. Sub-Q, fastest, really quick, less than 10 minutes. If a patient has severe nausea and vomiting, go sub-Q. Right? Why wouldn't you want to give them an oral pill? Because they're going to vomit it up. So you can try sub-Q or sublingual maybe, but sub-Q faster acting. Rapid escalation and severe nausea and vomiting, usually it's going to be that sub-Q sumatriptan. You also have rizatriptan, which is an oral disintegrating tablet. So that one is helpful with just nausea. If you're vomiting, I'd probably go subQ. You have an intranasal in the zolmitriptan. So basically just match the route to the severity. If they're vomiting, oral's not going to work. That's pretty straightforward. Here's the money slide for dosing. I already said it. 2 doses in 24 hours. Do not exceed 2 doses of any triptan in 24 hours. I.e., I can't do a 9 o'clock sumatriptan, then 11 o'clock sumatriptan, and then at 1400 I move over to a different triptan. It's any triptan, 2 doses, 24 hours. And this tends to be tested exactly that. Like the questions on the board will usually say, patient took a sumatriptan, or took triptans or sumatriptan at noon. When can they next dose? And it will be 1400, 2 o'clock. But 3 o'clock will be on there, 4 o'clock will be on there, 5 o'clock. But just know that 2-hour timing is what's important. And the max dose. So this just lays out a lot of the stuff we've already talked about. We talked about the different routes and the different treatments. So acute, the elatriptan, focatriptan, rizatriptan, sumatriptan. You also have the sumatriptan with naproxen, that NSAID and triptan you can use for acute treatment. And then the zolmitriptan, as I mentioned, you can do intranasal spray or oral. They all have a little bit different pharmacokinetic properties. Faster, subQ or intranasal. Somebody had a question? Patients should not respond to triptan, may respond to a different one. You can try a different one for that second dose, but you can't try a different one later that day. Obviously, nausea and vomiting, move to a non-oral type. 10 days per month. Limit. Less than 2 days a week to prevent MOH, medication onset headache, or overuse headache, I'm sorry. That's important, I would know it. Triptans, 10 days a month, or about 2 days a week. Contraindications, adverse side effects are there for you. Coronary artery disease, stroke, peripheral vascular disease, a hemiplegic migraine, and pregnancy is contraindicated with triptans. I mean, just think about what they do. It makes sense what the adverse effects are, right? There's vasodilation from activation of that trigeminal pathway and the vessel pathway on the 5-HT1 receptors in the cranial vasculature. So then we put on a triptan. It helps those, it is an agonist on those receptors, which now we're vasoconstricting. So anything that would be worsened by vasoconstriction, that would be it. Chest symptoms, tightness, pressure, heaviness, pain in the chest, neck or throat. SubQ, faster acting, what's that mean? It's going to constrict those vessels more quickly. So it's usually more so signs and symptoms, adverse effects than oral. A little quicker and a little more prevalent. You can get paresthesias, fatigue, dizziness, flushing, warm, you're vasoconstricting. Just think about all the things that can happen with that. Pain and injection site is your big one for subQ. Nasal, weird, unusual taste in your mouth because you're using intranasal inhaler. You can get hypertensive crisis, but it's pretty rare. Contraindications, uncontrolled hypertension, ischemic heart disease, CVD, Prince-Meadows angina, we talked about it before. Remember, that's usually your patient getting angina from, and they're at rest or at night versus that normal out mowing the lawn or some type of activity. It's that variant angina. Then we talked about the hemiplegic and basilar migraines. Pregnancy, no go. Don't use it within 24 hours of ergotamine. I think that's like the 3rd time in the slide deck that was mentioned. So probably important. And don't use another triptan other than the first 2 doses within the first within 24 hours. You can't stack triptans. And then it's don't use with CYP3A4 inhibitors. We've talked about those. Remember, the big players are your macrolide antibiotics and your antifungals. Serotonin syndrome, probably the most significant drug interaction to be aware of, and we'll talk about it in a minute, but it's anything else that increases serotonin, right? SSRIs, TCAs, MAOIs. Serotonin syndrome, you need to know it, the triad. Look at the percentages and you'll see the most common symptom for each of the different areas of the triad, which are cognitive effects, neuromuscular effects, and autonomic effects. So cognitive agitation, confusion, neuromuscular hyperreflexia, clonus, and tremor, and then autonomic hyperthermia or tachycardia. So you need to know that triad of the cognitive effects, the neuromuscular, and the autonomic dysfunction. You're going to think of this with a triptan and an SSRI or SNRI usually. There is a risk. It's not that common. However, boards test it, love to test it. Serotonin syndrome with an SSRI or SNRI. So you're going to get on the board that migraine patient, they're on sertraline, and then you're going to treat them, and they're going to get hyperreflexia, fever, after you give them that triptan. Serotonin syndrome will be your diagnosis. Serotonin syndrome, much like medication overuse. How do you stop it? You stop the offending agent first, i.e., whatever's causing too much serotonin to build up in the system, you stop it. So more than likely with the triptan, you're probably not going to be taking them off their SSRI, SNRI, unless it's an acute situation where they're in the ER or something like that, which they probably will be. But you can provide supportive care for those signs and symptoms, i.e. if they're hypothermic, get them cooled down. If they have anxiety, agitation, seizures, a lot of times we're going to put these folks on some benzoids. And then the one I need you to know about a pharmacological antidote is there at the bottom. Cryoheptadine, periactin, first generation antihistamine, and it acts as an antagonist to the same receptors that the triptans agonize. So partial. So that makes sense as to why it's a reversal agent. And then you've got your mechanism that's increasing your serotonin by drug there, which are your big players, which I think you're all pretty much familiar with. But I would know the pharmacological antidote to serotonin syndrome being cryoheptadine. Stop the offending agent, especially if it's an illicit drug, like the numbers on that right-hand side part, and then give them the cryoheptadine. Here's the sumatriptan with the NSAID combo, Trexamet, and you see the dosage there. Why does it work? Well, the triptan part helps vasoconstrict, and then we know what naproxen does on the COX pathway, decreasing prostaglandins and inflammation. So you're targeting both avenues of the migraine when you use this NSAID and triptan combo. You're hitting the vascular portion with triptan, causing vasoconstriction, and then you're decreasing inflammation with the NSAID. It's superiorly, clinical advantage is you're going to get superior relief because you're hitting both of those pathways versus just one of them. So really, your exam pearl to know about this one, if the patient partially responds to a triptan, then try a triptan with an NSAID. Try adding NSAIDs on. That way you're getting the combination of effect of hitting both pathways of the migraine. Here's orgotamine, thing of the past, so they're last. You will see it as a contraindication. You're not going. There's still patients out there that are on them. Some providers still use them, but there's other options. So We stay away from them because they're a non-selective serotonin receptor agonist, so they cause vasoconstriction, but it has a lot more side effects, a lot more nausea associated, much more strong peripheral vasoconstriction effect than the triptans. And we just talked about the things that could happen with a triptan. So now we're worsening those adverse effects. So not good. Like I said, it's an older drug. At one point, it was a go-to first line, but now not so much because of the severe peripheral vasoconstriction and the ischemia. Once again, we don't give it within 24 hours of a triptan because now you're causing vasoconstriction from two different drugs. You're going to get a severe side effect. This is usually just your refractory cases. So I put it up here. There's ergotamine and the dihydroergotamine. They're older. As I mentioned, they're non-selective. Side effects are real. And you're going to limit these to 8 days per month to prevent MOH, medication overuse, headache. It's really about all you need to know about them. Other than that, caffeine can potentiate increased vasoconstrictive. So if you're throwing in an ergotamine and some caffeine, those vasoconstriction side effects are going to be worse. About the same adverse and contraindications and drug interactions as your triptans, but the vasoconstriction component is worse or more intense. Really strong precipitator for the MOH headache, for the medication overuse headache. That's why they're not used as much. That with the increased peripheral vasoconstriction. Too much ischemia. And that's just the other derivative of it. Everything else is basically the same, except for it's a little bit weaker vasoconstrictor than the ergotamine. Adverse effects are basically the same. You do have one added on there with the fibrotic valve thickening, aortic mitral tricuspid with long-term use. But like I said, they're rarely used anymore. You still will see patients on them, folks prescribing them. For our purposes and board purposes, you're going to see it, that contraindication within 24 hours of a triptan. Same drug interactions. The macrolides and the azoles, antifungals being those CYP3A4 inhibitors, amongst some others that you need to be careful of interaction with the ergotamines. So we'll get through this question, then we'll take a quick break. All right, so the one on the left, which medication should not be given within 24 hours of a triptan? 3 and 2. True. 3 and 2. No triptan and no ergotamine. Both. All right. Mr. Williams prescribed sumatriptan, Imitrex, took 1 oral tablet this morning at 0.8. When can he safely take another dose? We beat that horse to death, right? All right, let's take 10. Okay.
Yeah. We're just like 2 kids on a sleepover. Seen from Step Brothers. Great. Do it, ma'am. You can join the weirdos. Okay, good.
Because I thought you could do two from different classes. I mean, they are the same class. Systems are class.
In theory. It's more than social media. But yes.
Big drink, big sips, huh? Big gulps.
That's what you're saying. They took one day. And now we're doing. I'll add that to this. Yeah. Because you can change it. There's one that's 4 hours. There may be one.
I honestly thought it was just 3. Still because it's a different one. But I thought it said that it was a different one. You should take those.
Yeah, I know it's 4 hours. Right. But the patient. No. You can only whichever one you need. So, a lot of people it was.
Coming up the stairs back.
It's 2 o'clock in the morning.
Fix that right now.
Dude, I took the last picture in the car. I'm like, who's this? And she's like, oh no. And I'm like, oh, exactly. It's your schedule to think about. He's like, how do you know? I'm like, I got my sources. And she's like, he's trying to ruin my fun. I was like, what the fuck? So what am I gonna go play pickleball? I was like, what happened? I was like, what happened to your whole nausea? Like, I didn't know pickleball was considered for.
Interesting. She just like every time she sees it, like
She's like, and she's practicing. I was like against the wall. And so she's walking.
Yeah, right. We're about to get 120 then. Is that why she's here?
I thought he was gonna make some.
Oh, yes, you're
What? Are you serious right now? Don't try it. Look at their faces.
They are
Can't trust them.
Yeah, I was, yeah, no, but I was thinking like you freeze it on it, and it's so hard to get another one in there closer. So like,
So we can get straight back. So just a couple of questions on this slide. Sumatriptan injection is not the 2-hour rule, right? The sumatriptan injection is 1 hour. So keep that in mind, and I told you there was one that's 4 hours and it's there, the nortriptan. There's a few questions, so I want to make sure everyone understands. The 24-hour period is 2 doses of whatever one you want to use. Not saying you can't give sumatriptan, and if it's, say you gave the injectable and it's 1 hour, can you use a different triptan? Yes, you can use a different triptan. You just don't add more than 2 doses of whichever one you're using in a 24-hour period. Everybody clear on that? Like, you can't just, well, I'm using a different one, so I'm stacking, now I can use 2 of these. Because there was a few people that were questioning that, yes.
So when it says on the drug interactions, do not use within 24 hours, regalimine or nontriptan?
I'm sorry, I can't hear you.
when it talks about it, the drug interactions, where it says do not use within 24 hours of ergotamine or another triptan, is that just saying that?
Okay, so another triptan, meaning another, you've had a full dose. If you haven't had your 2 doses in 24 hours, at the 2 hours or 1 hour or 4, you can use a different triptan. But you're not going and adding on additional from a different formulary of a triptan within 24 hours. 2 is all you got. You choose which 2 doses you're gonna use, but 2 is all you got. Then you gotta wait a full 24 hours if you wanna start mixing it up, or you wanna give them the one with combined with an NSAID. If you've given 2 doses today in that 24 hours, 1 dose, 2 hours later for most of the orals, 1 hour later exception for the 1 injectable sumatriptan, and 4 hours later for the nortriptan. Once you've hit those 2 doses, it's 24 hours before you can have any other triptan or an ergotamine, to answer this question. Everybody's good on that one? All right, moving on. No, it was a good question. The another doesn't mean like of another triptan. It's really any triptan if you've hit the max dose. Let me get back to where we were. So remember when we talked about the ergotamines not used as much anymore, but the adverse effects I went through. So make sure you familiarize yourself with the adverse effects and the contraindications. And we did the challenge questions, and now we're moving into miscellaneous agents here. So butorphanol, as I mentioned, is a partial mu opioid agonist and a kappa agonist. It is controlled substance, Schedule 4. Route IM IV nasal spray. Last resort, that's what you need to know about it. And I talked to you about why. Those side effects, right? Dysphoria, abuse potential, depression of the CNS system, fetal heart rate problems or abnormalities in pregnancy. So if you ever see butorphanol as a first-line migraine treatment, it's wrong. That's not what we're looking for. And oh, by the way, also any opioid is going to worsen that MOH, right? That medication overuse headache risk. So triptans and antiemetics over opioids every time. Antiemetics, like we mentioned when we gave you the pound and the snoop, nausea and vomiting, going to lead you towards that migraine diagnosis. Metoclopramide, Reglan, dopamine antagonist, useful adjunct, right? That's going to combat the nausea and vomiting associated with the migraine. Be given PO or IV. Most effective for migraine-associated nausea and vomiting. I would know that. You can use it alone for acute migraine, but it doesn't have as good of efficacy as using it with a triptan. Adverse effects you need to be familiar with that you've heard, the EPS, right? Extrapyramidal symptoms. Remember those? TD, tardive dyskinesia, all those things, the muscle rigidity, the slow movement, the unwanted muscle contractions. Everybody with me? Know those. You'll also see an antiemetic used, chlorperazine, first generation antipsychotic, strong dopamine blocker, IVIM or PO. You'll also see chlorpromazine, but that is not your first line because of the QT prolongation risk. Ondansetron and granasterone, the 5-HT3 antagonist, not first line for migraines either. You need to know that. They can also prolong QT. So if a patient has a migraine, severe nausea and vomiting in the ER, IV metoclopramide or chlorperazine is appropriate. And then we talk about those side effects, potential side effects. And there's a video link at the bottom if you want to go back and revisit the EPS. All right, challenge question. 50-year-old female, no significant past medical history, would like assistance managing her migraines. She tried ibuprofen in the past, but it failed to relieve her pain. What is the most appropriate recommendation for this patient? Switch to a triptan, straightforward. What if she's having to take triptans more frequently? More than twice a week. Prophylaxis, right? All right, which is where we're at now. Migraine prevention or prophylaxis. That top box is important. These are all the medications that are first line. You see them there? So we will hit each one briefly here in a moment. We'll go over the amitriptyline, the Valprox or the Depakote, valproic acid, and propranolol. As I mentioned, when you see some of these class of medications like the ARBs or the beta blockers for prophylaxis, it's specific drugs that have been studied that show the most efficacy for migraine prophylaxis. So it's not the entire gamut of ARBs or beta blockers. The ones that are on the slides and the one we mentioned are the ones that have been tested to show efficacy in prophylaxis for migraines. Usually you're looking at the patient as a whole. What are their comorbidities? So which one of these agents do we want to add on based on they have a migraine and what else going on, right? And we'll talk about each of those. When do we start it? We already talked about it. More than 4 headaches a month or 8 headache days a month. Or if they're having significant disability, if they're having a failure of acute therapy, or if they're at risk to that medication overuse. And I gave you some guidelines for some of the agents if you're using them more than so much per week or per month when we're going to add on think prophylaxis. Prophylaxis and migraines very underutilized. Like 30% of migraine sufferers would benefit from it. About a third of that actually get it from their provider, like 13%. So if patients having abortive therapy or migraines that are happening on those at that frequency threshold, i.e. the amount of headaches they're having or the amount of times they're having to use abortive therapy to include triptans, that's when we're going to go to prophylaxis. Not add no opioid or not, hey, take triptans more than 3 times a week. If they're at the thresholds we mentioned on the other slides, it's time to add on prophylaxis. And those are your big agents or your primary first-line agents up top. So why it matters is basically this slide. Why prophylaxis matters, right? It's preventative, reduces frequency of headaches, reduces severity of the headaches, reduces patient disability from the headaches, prevents progression into more chronic migraines, and you're going to decrease that MOH risk. So if a patient's missing work, has more than 4 migraines a month, they need to be put on some kind of preventive therapy, some kind of prophylaxis. Or if you're using that triptan greater than 2 days a week, you're already behind the power curve, right? Time to have already started prophylaxis. And the indications are there at the bottom again, as mentioned on the other slide. 4 headaches a month or more than 8 headache days per month. So the prophylaxis prescribing principles. These are important rules to know. You're going to start slow, and you're going to titrate that prophylactic agent from that first line list we gave you every 2 to 4 weeks. Could take months, could take up to half a year to get the full benefit from your prophylaxis. 2 to 6 months. Reassess every 1 to 2 months to see how we're doing. And then if they're controlled with prophylaxis for 6 months to 12 months, then we slowly start to taper the patient off. See how they do without the prophylactic treatment. Just remember, preventive prophylactic therapy is not immediate. This isn't just you're not going to start on one of those agents and then, oh, look, no more migraines. It's going to take time, and you're starting at a really low dose and titrating up, and then to get that full effect could take a significant amount of time, 2 to 6 months. And then you have them coming in, follow them for a few months. If they've been headache-free and it's working and they're well controlled for half a year to a year, slowly start taping them off. The key is preventive or prophylactic therapy is not as needed. So medications recommended for episodic prevention. It's the same ones on the other slide. The two ARBs mentioned there, the calcitonin gene-related peptides. We're going to talk about them a little bit more specifically than I hit them earlier. Amitriptyline or Elavil, the Depakote or the Davoproex, Provitriptan is obviously a triptan, beta blocker propanolol, and then topiramate, Topomax, and then Topamax. Then below you'll see the second line, and then there's a breakout of the amitriptyline, the beta blockers, then lofacine, and you'll see the second line there. And pay attention to that box, because you see where certain medications would lead you, based on the comorbidities of the patient, lead you towards which of the prophylactic agents that you should look at putting them on. So the ARBs, they're underutilized, they're effective, excellent if they have hypertension, right? I know we had hypertension, we discussed it, so ARBs, obviously first line, one of the first line choices. So if they're having migraines and hypertension, ARBs would be a good choice. And the rest of those are broken out there for you as to why that would be a better choice for prophylaxis based on comorbidities. We'll hit those on the next couple of slides a little more in depth. There's the beta blockers, the three first line recommendations, propanolol, latenolol, nadolol. We know what the mechanism of action of the beta blockers are. But in migraines, it's likely central modulation of adrenergic tone. Propanolol is the most studied at the beta blocker class for migraine prophylaxis. Start low, titrate slow. Your patient that you would want to look at probably starting on beta blockers is if they have hypertension again, performance anxiety, or they have a tremor. So think propanolol if it's migraine with those other comorbidities. Avoid, and the reasons we always avoid beta blockers, right? Asthma, bradycardia, heart block. Same reasons we would avoid beta blockers for any patient. So the Topamax or topiramate, it's a GABA enhancer. It blocks voltage-dependent sodium channels. The side effects of paresthesias, weight loss, kidney stones, cognitive slowing. So these are all broken down in the chart for you. You don't need to know all of them, but you need to familiarize yourself with the side effects for using topiramate as your prophylactic agent. Migraine and obesity, you want to start thinking topiramate because it's a weight loss benefit as a side effect. So obese patients with migraines, think about topiramate. Kidney stones, avoid it. I just told you one of the adverse effects is kidney stones. So if the patient has kidney stones, don't use this as your prophylactic agent. So the Davoproex or Depakote, it enhances GABA activity. It's the opposite. It causes weight gain as an adverse effect. Also tremors, hair loss, and liver toxicity. So you're not going to go with Depakote or Davoproex if your patient has liver disease, underlying liver disease. It's teratogenic, so it can't be used in pregnancy because of neural tube defects. Avoid it in pregnancy. So if you have a migraine patient, female childbearing age, beta blockers of topiramate safer than valproate. Then we have amitriptyline or Elavil. It's a TCA. You had it last semester. So obviously it's inhibiting serotonin and norepinephrine reuptake. So you can use this sometimes if your patient has insomnia and migraines. So the amitriptyline can help with insomnia, depression, But adverse effects, anticholinergic. You know those. Weight gain again. QT prolongation and orthostatic hypotension. But your ideal patient, migraine, depression, and insomnia, and amitriptyline. Like I said, we're basically just looking at the comorbidities to see which prophylactic agent makes more sense in this patient. And also which ones should we not use, i.e. pregnancy and kidney stones. Then the ARMS, candesartan and telmisartan, as I mentioned, they're underutilized. Likely their mechanism for the migraine prophylaxis is central angiotensin modulation. As I mentioned, migraine and hypertension, it's a first-line antihypertensive. Let's use it. If a patient can't use beta blockers as their prophylactic agent, can't tolerate them for some of the contraindications we discussed, look at an ARB, reasonable alternative there. And now we get into the calcitonin gene-related peptides. So I mentioned to you what happens in your body. It's a neuropeptide. So I mentioned how CGRP contributes to the inflammation and the pain with the migraine. So you can give the calcitonin gene-related peptides as an injection, which is called monoclonal antibodies, or you can take an oral pill. Then we're going to call them calcitonin gene-related peptide antagonists. So basically it's blocking the effects of CGRP. That during the migraine, remember the CGRP levels are going to go up by that neuromodulation. Then what's going to happen on the other receptors, vasodilation, right, in those cranial blood vessels. And then it also leads to inflammation, it being CGRP. So if we block it with either a monoclonal antibody injected or we give an oral pill, then we're going to decrease those effects. So FDA approved the CGRPs for episodic and chronic migraine prevention, and you'll see there's one there that is also used for treatment. They're all in the red box. Well, actually, most of the red box on the top left, or the far left side. And as I mentioned, the oral ones are the antagonists, and the monoclonal antibodies are the injectables. And that can be some differing time frames for how often you have to give the injection. So strongly recommended by the VA DoD study for the CGRPs as a prophylactic agent. The injections sometimes are monthly or quarterly. You can see them in the chart there. And you can also see the reasons to avoid them would be patients with a recent cardiovascular or cerebrovascular ischemic event. And the CYP3A4 inhibitors interaction. Note under the comments there. And if you notice the suffixes on those, you can pick them out by the suffixes, the antibodies versus the antagonists, the injectables versus the oral. The orals are the PANTs, right? P-A-N-T. Ravagepant and atogepant, the small molecular CGRP receptor antagonist. So the ravagepant is acute treatment and prevention and prophylaxis, whereas the atogepant is prophylaxis or prevention. These are not triptans. They do not have the same mechanism of action. They do not cause vasoconstriction. They just block the CGRP. So they are safe in patients with cardiovascular disease. That's an important note. We'll get in a little deeper on the CGRPs here. The antagonists, CGRP calcitonin gene-related peptide that I said. CGRP goes up with a migraine, leads to vasodilation and inflammation. These medications, the CGRP antagonists or monoclonal antibodies block it, block the activation of CGRP. I mentioned what they were FDA approved for, and the DoD study of 2023 makes a strong recommendation for them in prophylaxis. If the patient's failed 2 to 3 traditional preventatives, i.e. prophylactic methods, those first lines we talked about, then CGRP monoclonal or oral is appropriate. And we talked about what the first lines are in that box: the beta blockers, topiramate, dalvalproex, amitriptyline, and then the CGRP monoclonal antibodies or antagonists would be our strong modern option for prophylaxis. And here's your injectables. These are your UMABs, whereas the orals were the PANTs. And I talked about the mechanism. And we'll hit here in a second how CGRPs can also be utilized in cluster headaches. Remember, if you failed 3 preventatives, we can think about the CRGP monoclonal. Yes. Which what? For migraines? There was a whole bunch of them once I mentioned that it was contraindicated. So we'll have to go back to the list and list with me. It's a long list of the medications that we can use. Are you talking prophylaxis or treatment? Okay, yeah, I can talk to you afterwards, but we can go through them. If it's contraindicated in pregnancy, I'll point it out, both in the acute treatment meds and the prophylaxis meds. All right, now we're talking about tension type headaches. Different primary type headache, right? Most common, not a migraine. Why? It doesn't fit into the PHARM category, right? It's bilateral. It's non-pulsatile, band-like, and there's no aura. There's no changes or pre-drome, prodrome. You don't feel the headache coming, no changes with lights, no change in your vision or blind spots, no cognitive changes, no aura. There's no nausea and vomiting typically. So now you can see how using the Snoop or the Pound lets you know migraine or secondary headaches you need to be worried about with red flags. Well, tension doesn't fall into either category, right? It's bilateral, band-like, non-pulsatile, no aura, no nausea and vomiting. Disability is usually mild from a tension headache. You're going to see it on your boards as a dull pressure hat band-like distribution of head pain. That's a tension headache. That is not a migraine. Migraine is going to have the pounding features. Most common primary headache, tension type headache. Lifetime prevalence is very high. Peaks between 20 and 50 years old. And all this is on your slide. Most patients don't even seek care for a tension headache. Disability is usually low or mild. So likely this has a myofascial factor, muscle tension. Central pain modulation may contribute in chronic cases. If the headache's bilateral, non-pulsatile, and mild, you're going to think tension. I gave you the classic description. Bilateral hat band, dull, tight, pressure-like, not pulsating, with no aura, and no significant nausea. Also, a big differentiator is that routine activity is not going to worsen the pain. So this isn't going to be your migraine patient that's looking for a dark, quiet room and avoiding any kind of stimulation or avoiding any kind of activity. Like their disability is huge. And this patient, disability is low. So if you see pound signs with pulsatility and nausea, think migraine. If it's absent, it's a hat-like band, squeezing, pressure, both sides around the head, think tension. How do we treat it? This is the most straightforward of all. Tylenol doesn't work, NSAIDs, insults, that's it. No triptans, no ergots, no opioids. Tylenol and NSAIDs. You still want to limit any kind of OTC combination for tension headaches less than 15 days a month to prevent that MOH. So folks will take Excedrin, right? Pop Excedrin. So if they're using it more than 15 days a month, then their headache may be being caused from medication overuse, not necessarily the tension component. So prophylaxis, if they're having very frequent tension headaches, we can consider it. Or if they have chronic tension headaches, or if they're having significant disability, more than I described earlier in your normal presentation for the tension headaches. Drug of choice is amitriptyline. Amitriptyline, prophylaxis for tension headaches. Different than some of the other, the migraines when we talk prophylaxis, we gave you the big list. There are some others, but they're there, the limited data there at the bottom, but still has some statistically significant results. But drug of choice is the TCA amitriptyline for prophylaxis for tension. Usually going to start it at bedtime, and you're going to titrate it like all prophylaxis treatments. Start low, titrate it up slowly. I know we don't test you on dosing, but usually we're going to go up to a max of about 100 milligrams for prophylaxis treatment of the tension headache with this medication. Amitriptyline is ideal, as I mentioned on the other slide, if they've got chronic tension headaches and they have insomnia. You can use nortriptyline as well, but it's less sedating. So not going to get that insomnia treatment as much as you will from the amitriptyline. And I mentioned the other classes, the martazepine, the venlafaxine, and the gabapentin, and possibly topiramate. But you'll usually see on boards amitriptyline prophylaxis, first line prophylaxis for tension headaches. Consider nortriptyline if amitriptyline is contraindicated. Now, cluster, the most dramatic headache type we're going to discuss of the three primary. Not fully understood. We suspect hypothalamic dysfunction, maybe circadian rhythm involvement. Often these are at the same time of day when you have this acute attack, often at night, and they can be seasonal, spring, fall. There's probably a genetic component to it. First degree relative equals a 14-fold risk. So first degree relative with cluster headaches, 14-fold risk elevation for patients. If it occurs at night at the same time, think cluster. Most severe primary headache, it's excruciating. Tension most common, cluster most painful. Unilateral, usually periorbital or temporal, so side of the temple, around the eye. Associated with ipsilateral autonomic symptoms. I would know these. So lacrimation, rhinorrhea, conjunctival injection, ptosis, meiosis. Everybody knows what those words mean, right? We've had them all. So if you're having ipsilateral autonomic symptoms with unilateral or periorbital or temporal severe headache, think cluster, especially if it's occurring at the same time at night. Somebody have a question? With what? They're on the slide. Is it not up there? Okay, yeah, I'll throw it up there. Gotcha. I thought it was on the slide, but I'll get you one when I put up the pound and the stupid. Yeah. So for those of you that want to hear it again, lacrimation, rhinorrhea, conjunctival injection, ptosis, meiosis. And then the behavior is going to be different from a migraine patient. Migraine patients, like I said, cold, dark room, no stimulus, no stimulation. Cluster patients, cluster headache patients like to pace and walk around. Very different from migraine. Also with the symptoms. So, but know that cluster patients pace and rock. They're episodic. These cluster headaches, they can last weeks and months. And then they can go away, and they can be gone for months and even years. You can have chronic cluster headaches with no remission or remission less than a month. So highly variable. You can have 1 to 8 attacks per day. It peaks usually quickly, like 15 minutes up to 180 minutes. So, quarter of an hour all the way up to over 2 hours, 2.5 hours, 3 hours. Short, intense, multiple daily attacks with those autonomic signs, but that cluster of symptoms equals cluster headache. And once again, this slide points out the ipsilateral symptoms. And like I said, I'll add that slide on. Treatment, first line, oxygen, 100%. By non-rebreather facial mask, 7 to 10 liters per minute, 15 to 25 minutes. Usually no adverse effects from that. Very different from migraine, right? High flow oxygen, non-rebreather. We can also give sumatriptan sub-Q. It's effective for clusters, but oxygen is the classic board question. If you got a cluster headache, acute attack, think oxygen, not NSAIDs, not opioids. Consider the sumatriptan, but oxygen's your first line. Last line there, we have the ergotamine derivatives listed that we mentioned earlier, and then the CGRPs. Specifically just galcanezumab for episodic cluster headaches. There on the bottom right. Prophylactic treatment changes from migraines and from tension. Now it's verapamil. What class is verapamil?
DHP.
What type of calcium channel blocker? Yeah. Okay. 70% effective, about 70% in patients. You won't be tested on the dose, but it's usually like 240 to 480 milligrams a day. Your patient may need high-dose verapamil for cluster headache prophylaxis. We can use prednisone or steroids initially as a bridge when we're getting that verapamil up, titrated up. Can use steroids as a bridge therapy. So know that prophylaxis is verapamil for cluster. Not beta blockers, not amitriptyline. Different from the other two, right? That's why I mentioned in the first lecture, we're going to talk about a lot of different medications, but we'll talk about treatment agents for acute abortive for those 3 primary types, and then also the prophylactic. And the last 2 have been very specific as the primary choice. Verapamil being the primary drug choice for cluster headache prophylaxis. An important nuance is that if you start getting those high doses of verapamil, we might need to monitor the ECG at higher doses, risk of a heart block. You don't need to know the prednisone dosage, but it's 60 to 100 milligrams a day for like 5 days. Bump them up as a bridge as you get the verapamil titrated up. Not long-term therapy with the steroid. So basically, if the cluster headache just started and it's severe, as you get them on the verapamil, you can go ahead and add the prednisone as a short course to bridge. We can also use lithium for chronic cluster prophylaxis. It's less common, but it's used in episodic cluster, like when they're coming over and over and over again. Adverse effects from the lithium can be nausea, diarrhea, tremor, ataxia, drowsiness. The big one here, why don't we use it more? Because we've talked about lithium in other, last semester probably, and it's the side effects, nausea, diarrhea, tremor, ataxia, drowsiness, and then the monitoring is a big one for lithium, right? Monitor the kidneys, the thyroid, the LFTs, and the lithium level. So it's a monitoring burden. That's why it's not your first line. But if verapamil fails as a prophylactic treatment, we can consider lithium, knowing it comes along with those mandatory monitoring tests and lab draws. We can also use topiramate adjunctively, Topamax, if you combine that with the verapamil. Okay. And same with lithium, it can be combined with the verapamil. So verapamil is always your first line. You can combine them. If the patient can't tolerate the verapamil, you can try the lithium on its own. And then you can also use ergotamine, which we talked about for the migraines, in the evening for cluster attacks that occur only at night. And then the galcanezumab, as I said, the UMABs, CGRP, monoclonal antibody, can be used as a cluster headache prophylaxis, just like it's used as the cluster headache prophylaxis for migraines. But know that it's just that one medication that can be used for the cluster headache prophylaxis, and we talked about the oral and the injectables that can be used for migraine prophylaxis. So basically, if you have a refractory cluster patient, you can consider adding the CGRP monoclonal. Verapamil first. Try verapamil first. And good old memory jogs.
Oh, yeah.
All right. So the memory jogs are there. I won't go through them again. It's basically, if you looked at them, it's all the things that we discussed. Obviously, it's not everything that's going to be testable on your exam. I will hang 3 to 4 of the check on learning questions tonight and the 2 slides that we just discussed. So that's all I got for you today, and I will see you tomorrow to discuss osteoporosis.